It is potpourri. I would request the chairperson, Sai Kandula and Sadashiva Rao on the stage. Chairperson Sai Kandula is a consultant diabetologist at Diabetic Care Hospital, Rajmundry, AP, and Executive Committee member of Diabetes India, active member of APDRF and RSSDA chapter of AP. Welcome you, sir. Has co-authored more than 15 publications. Sada is not. Okay. Since there is only one chairman, Sadashiva Rao has not come, I think so.
Good evening, everybody. Let us not waste time. Let me introduce the speaker, Avdesh Kumar Singh, Senior Consultant Endocrinologist, Diabetologist, GD Hospital, Diabetes Institute, Kolkata, Distinction and Certificate of Honors in Pharmacology, T.N. Ghosh Memorial Award, Medical Scholarships for the Best Student of Internal Medicine, Calcutta University, Speaker and Chairperson, Association of Physicians of India, Research Society of Study of Diabetes in India, Endocrine Society of India, co-author in Indian Insulin Biosimilar Insulin Guidelines, contributor, author, API Textbook of Medicine 2013 and 14, around 75 publications in the peer-reviewed journals. Will you speaking on enough? Yeah.
Thank you, Chairman, for the kind word. Thank you, organizer. Team Debate 2020. So now I am back with natural intelligence. Unni talked about artificial intelligence. Let's stick to what intelligence God has given to you and decide. We have to wait for next 30 years to believe upon artificial intelligence. A number of times that might not be correct. That's called technical failure. So let's believe on what the God has given you in the form of a structure, organ called brain, and decide how to treat diabetes. And with the rampant DPP-4 inhibitor in Indian market, I have been given a job to find out a difference, the nuances that differentiate these DPP-4 inhibitors. I may recall that I used to give this talk 10 years back when gliptins was launched to look into difference between different DPP-4 inhibitor. But this topic has resurfaced now, given that market has been bombarded with number of gliptins. In particular, when vildagliptin lost its patent, we have got 35 to 40 company now came up with vildagliptin. Someone is selling in 15 rupees, 25 rupees, someone is selling up to 6, 7 rupees. I fail to understand how could the difference in the cost in India itself in one country with 35 company can be different, ranging from 25 to 7 rupees. Is there any quality control? Is someone looking into that? That is the big question. But I'm happy that we have got now a molecule which is cheaper, we can afford to our patient. At least this data of vildagliptin is far, far better than the other gliptins, tenaligliptin, which was there in the market without any good medical evidence. So with this background knowledge, let's look into what are the nuances which one should consider with a natural intelligence when you are selecting a DPP-4 inhibitor. So I thought that these could be the points upon which we can select different DPP-4 inhibitor. The first one, let's go to the pharmacology to understand why we need a selective DPP-4 inhibitor. A DPP-4 inhibitor has to be very selective. It has to block only DPP-4. There are a number of DPP substrate which we are not supposed to inhibit when we are using a DPP-4 inhibitor. So this DPP inhibitor has to be very specific to DPP-4 substrate out of the entire DPP substrate enzymes. And then whether this DPP-4 inhibitions, what is the quantum and difference between these, and so on and so forth. I will take one by one each. So let's understand why we need to have a very selective DPP-4 inhibitor is in preclinical studies, it has been found that if you are not specific to DPP-4 enzyme and if you block other DPP enzymes like DPP-8 and 9, then you have got variety of side effects that was seen in preclinical studies. Whether this translates into the similar kind of side effects in human being is exactly not known, but considering that if diabetic patient has to take anti-diabetic drug for 10, 20, 30 years, and what would happen with this non-specific DPP inhibition in the form of DPP 8 and 9? There are studies which suggest that if you block DPP 8 and 9, you can have decrease in WBC count, decrease in spermatogenesis. And if you closely look into the sexagliptin PI, still maintains that it causes lymphopenia. There is reduction in the granulocyte and lymphocyte with sexagliptin. Vildagliptin is also very non-specific DPP4 inhibitor, and if you see the UDRA vigilance data, the highest prevalence of any skin reaction starting from a simple allergy to a Stevens-Johnson syndrome has been reported with vildagliptin, highest in the entire class of DPP4 inhibitor. We don't know exactly whether it is related to this non-specific DPP inhibition to other substrate like DPP8 and 9, but then people hypothesize that this could be one reason why these side effects are commoner in this two DPP4 inhibitor, which is less selective to DPP4 enzyme. And that's why you have got this chart to understand which DPP4 inhibitors are very selective to DPP4. In the list, if you see the highly selective DPP4 inhibitor, allogliptin, sitagliptin, and linagliptin comes first. Sexa and vilda is list, and somewhere in between is tenali and ibogliptin. Now, is it clinically meaningful, as I was just alluding to? We don't know exactly, but then perhaps because of these non-specific abilities of sexa and vilda, they do have more skin reactions or lymphopenia respectively. What about this DPP4? How much DPP4 inhibition you need to produce a statistical decrease in blood glucose? So if you see the different DPP4, this is a very landmark paper by Caroline Deacon. This is the lady who discovered basically DPP4 inhibitor. And these have, this table in front of you is not a head-to-head trial of different DPP4 inhibitor together. And this data has been taken from an individual DPP4 inhibitor trial. However, this trial suffices to suggest that at the top of list, two gliptins comes, which is sitagliptin and vildagliptin 50 milligram twice daily, which has got a highest DPP4 inhibition immediately after ingestion, ranging from 95 to 97. And 24-hour post-dose after the drug also, there is a 80% DPP4 inhibition. It is considered that if a DPP4 inhibitor which could not inhibit the DPP4 by more than 70% may not have a good glycemic effect. So if you see down the list, somehow we feel that other DPP4 inhibitor 24-hour post-dose may not have that much glucose lowering potential. But then this is the pharmacokinetics. Whether this translates into any real clinical difference is the need of the hour. However, after this publication, there was only one trial which was published where a 3 DPP4 inhibitor was compared head-on. So you can see the black, one is with sitagliptin 100 milligram once daily, red one is with vildagliptin 50 milligram twice daily. The green one is with sexagliptin 5 milligram once daily. Also, you have got in a lower panel placebo, and blue color is 50 milligram vilda once daily. What is very important to understand that clearly, if you see the DPP4 inhibition, it is best with sitagliptin 100 milligram once daily and vildagliptin 15 milligram twice daily. So when you are using once daily of vildagliptin, be careful that glucose lowering ability is also 50% less when you are using the half dose. So this is the trough percentage of inhibition. If you see the what happened after administering these DPP4 inhibitor, 24-hour down the line, again you can see that sitagliptin has got a longer DPP4 inhibition, 5 days after the administrations, and also similarly, the vildagliptin is closely following, although following sort of sitagliptin 100 milligram. Whether this difference in pharmacokinetics would have a different meaning in glucose lowering, that as a clinician we would like to see. When it comes to tenaligliptin, unfortunately, tenaligliptin has perhaps got a weakest DPP4 inhibition. In a recommended dose, you can see there is 66% reduction in the DPP4, 66% DPP4 inhibition. The best DPP4 inhibition with the tenaligliptin lies in the range of 80 milligram, which is not supposed to be used because at 40 milligram, there is a significant increase in QT interval with tenaligliptin, and that's why this 80 milligram dose is not recommended, although this has got the best DPP4 inhibition in the dose finding studies. So let's look into the HbA1c lowering, whether these difference in DPP4 led to difference in the glucose lowering. So we do have few head-to-head trials comparing these DPP4 inhibition. So this was the first trial of sitagliptin compared to sexagliptin. You can see there are numerical difference of 0.1% better glucose reduction with sitagliptin compared to sexagliptin. In another studies, again you can find out there is 0.5% difference in HbA1c reduction between sexagliptin and sitagliptin. Seems to be clearly winner when you are comparing with sexagliptin. And again, I would like to remind you, if you go back to see the DPP4 inhibition in the head-to-head trial, the sexa had 70% reduction DPP4 inhibition, whereas sita had almost 95 to 97%. Also in the trial that has been translated to show that sitagliptin lowers blood glucose better than sexagliptin. Although if you meta-analyze entire trials of sita and sexa altogether, hardly there is difference, but still it is better with sitagliptin by 0.1% of margin. When you are comparing sitagliptin to linagliptin, this is one Japanese study where 50 milligram of sita was compared to linagliptin 5 milligram. There was exactly similar HbA1c reduction. So indirectly this suggests that linagliptin 5 milligram full dose is equal to the half dose of sitagliptin, that is 50 milligram. But this trial was done in Japan where the recommended dose is 50 milligram with sitagliptin. Also we do have one trial, this was done from BI, where the sitagliptin was kept as an exploratory analysis, but you can clearly make out, although this trial was not a head-to-head trial, but indirectly this suggests that there is relatively better glucose reduction with sitagliptin compared to linagliptin. With regards to the vildagliptin, there is a close fight. So if you see the trials which is sponsored by vildagliptin is trying to suggest better glucose reduction. When the trial was done with sitagliptin manufacturer, they are trying to suggest they are better. So I presented two slides in front of you. One is a small trial of 2 weeks showing vildagliptin to be better than sitagliptin. And in your right hand side, this is a longer trial of 24 weeks suggesting sitagliptin is better than vildagliptin. So what this suggests is they are very close by. And then there are some trials which also compared with between these two drugs to understand the glycemic variability. So this is a trial head-on between sita and vilda. You can see similar HbA1c reduction. You can see similar fasting and prandial glucose reduction. However, this trial suggested that there is a better glucose variability reduction with vildagliptin compared to sitagliptin. It is amazing to know that when a drug has reduced fasting, prandial and HbA1c similar, how could the glucose variability would be better with one drug? As I suggested, this trial was sponsored by Novartis, so they at least tried to find out something better out of nothing. So then there is another trial done which is called Optima study. They again compared the glycemic variability between sitagliptin and vildagliptin, and there was no difference between sitagliptin and vildagliptin on glycemic variability. I would be failing to show you the data. We have got very recently head-to-head trial of tenaligliptin compared with sitagliptin. So this was a trial done in patients who were already receiving sulfonylurea and metformin, and tenaligliptin was found to be amazingly equal to sitagliptin. Although if you closely look into this study, the baseline HbA1c was relatively higher in the tenaligliptin arm and compared to sitagliptin arm, and this is what the sponsor is going to do to make it equal. However, this study suggested that tenaligliptin has similar glucose lowering abilities like sitagliptin. Another study head-on done with evogliptin. This was even better trial because this was compared in only metformin background. If you do a trial in a sulfonylurea background, this is subjected to be biased, because then you can change the dose of sulfonylurea in one arm and try to prove superiority or equality. But when you're doing a trial with metformin, it is unlikely to have such kind of bias. In this trial, comparing head-on evogliptin to sitagliptin, again there was a similar HbA1c reduction, but numerically better HbA1c reduction was seen with sitagliptin compared to evogliptin. So in terms of HbA1c control, what I believe that almost all are similar. Maybe sita and vilda is on the top rankers in terms of glucose lowering, and immediately followed by linagliptin, evogliptin, tenaligliptin in this list. What about the pharmacodynamics in terms of drug interactions? So if you see the difference between these DPP4 inhibitors, there is quite things to understand. There are kind of interactions between the 3-DPP4 inhibitor. The highest drug inhibition, drug interactions seems to be with sexagliptin. You have to be careful when you're using a cytochrome P450 inhibitor or inducer. With linagliptin, there is contraindication to use with rifampicin. So if someone receiving tubercular drug, you have to be careful. You have to stop linagliptin. The vildagliptin has got one peculiar interaction with AC inhibitor, that if you use vildagliptin with AC inhibitor, there is increased incidence of angioedema with vildagliptin. Fortunately, sitagliptin doesn't have any interaction so far in the literature. And why I said about vildagliptin that if you look into these papers, I have just quoted one paper, there are 4 to 5 papers suggesting that vildagliptin has got highest incidence of angioedema if you use with AC inhibitor. In fact, this paper in hypertension suggested that if you're using vildagliptin, don't use with AC inhibitor, preferably use ARB with vildagliptin, not the AC inhibitor, because of the fact that you can see there was a several-fold increase in angioedema if you use AC inhibitor rather than ARB with vildagliptin in this particular study. Teneligliptin, this is what one editorial I wrote a few years back. You can see people claims that vildagliptin on this therapeutic dose doesn't have, you can see 40 milligram, which is also the recommended dose, has basically increased the QT interval. You can see the upper bound of 90% CI is reaching up to 10, means this drug has a potential to cause QT prolongation. And also need to understand that you don't use teneligliptin alone, you use with many other drugs which has a potential to increase QT. Hypoglycemia itself is the very powerful QT prolongator. So if you are using with sulfonylurea and a teneligliptin, you have to be careful that even a dose of 20 milligram may have a potential to have a prolonged QT, because hypoglycemia will itself prolong the QT. So these are the reasons why one should be very careful, and even in patients with diabetic kidney disease, because of increased in serum concentration of teneligliptin, you can develop increase in QT interval. When it comes to route of elimination, you need to understand that these drugs are eliminated through different route, and you need to reduce the dose. I'm sure you are aware. But then I would like to show you the alteration in the chart in different liver and kidney disease. This is the same paper by Caroline Dickon. At that point of time, vildagliptin was not allowed in a patients with even kidney disease. You can see here with vildagliptin, it's not recommended. But recently, vildagliptin has been given approval to be used in kidney disease with half dose. But this is absolutely contraindicated in patients with liver disease, and that's why if you are using vildagliptin, you have to monitor SGPT 3-monthly interval. Earlier, when vildagliptin was given approval, you need to do SGPT prior to vildagliptin, but that warning has been taken off. The only warning is right now that if you are using vildagliptin, you need to check SGPT at a regular interval, and you can't use in a patient with mild to moderate hepatic insufficiency. Finally, I will come to the cardiovascular safety, which is the most important consideration when you're talking about DPP4 inhibitors, especially in the modern evidence-based era. So what happened in these CB outcome trial, I'm not going to detail because of paucity of time. You know, the first trial was Sebatimi, followed immediately by Examine, and then Tecos, and very recently Carmelina. What you can see that these trials are basically neutral trials, suggesting cardiovascular neutrality with all the DPP4 inhibitors, especially these 4. However, there was increase in heart failure hospitalization by 27%, which was highly statistically significant with sexagliptin. Examine also had some signals, but it wasn't statistically significant. However, FDA put an alert with both sexa and allo not to be used in patients with heart disease and kidney disease because of fear of increase in heart failure. The Tecos came third, trial came neutral. You can see nothing, no signal whatsoever. Similarly, Carmelina also came absolutely neutral with linagliptin compared to placebo. The one there is lingering issues happened with Carmelina was there was a trend in increase in non-fatal MI with the linagliptin arm compared to placebo. Now, if you are really a purist, you can see the Examine trial had very small signals of increase in heart failure, yet they got this level of heart failure. What about the Carmelina when there is 15% increased trend in non-fatal MI? Should I leave it like that, or one should be careful if someone has got established heart disease? When you are comparing these two trials, both the trials are pretty similar in terms of having a patient with established kidney disease, heart disease and kidney disease put together. In TECOS trial, everyone had established heart disease. The only 20% had kidney disease, whereas in Carmelina, only 15% has established heart disease, while 60% had established heart disease. But the TECOS trial was such a big trial that if you actually calculate the 20% patients who had a CKD and 100% patients with established heart disease, if you combine together, the patients in TECOS had much more sicker profile compared to Carmelina. So I feel that both the trials perhaps had a similar kind of patients cohort. One had established heart disease, more patients, one had more kidney disease patient. But one thing which differentiates between two trials, that there was no single Indian patients in Carmelina trial, but there were more than 1,000 Indian patients in the TECOS trial. So what happened basically in the DPP-4 trials? All were neutral. Something unique came in TECOS which was not seen in other 4 CB outcome trial, that this sitagliptin trial suggested that these drugs are absolutely safe in elderly. On your left hand side you can see what happens to the elderly population. All complications are high. In the TECOS trial, if you see the sitagliptin arm compared to placebo, everything was completely neutral. That is very interesting finding. The TECOS trial was the first randomized control trial which suggested that a DPP-4 inhibitor can have exaggerated glucose reduction in East Asian compared to Caucasian. You can see the entire chart. And what I was more interested about, that the TECOS has got a very interesting data which perhaps you have not come across, although TECOS was a neutral trial. But if you see gender-wise difference in the TECOS trial, there was a benefit in the women in the TECOS trial, which I was not aware when I was looking through this data. If you see the cardiovascular mess, or if you see the all-cause mortality, the female tends to had superiority over their male counterpart in the TECOS trial. That's one unique finding happened in the TECOS. And finally, if you see the TECOS trial, if you see all-cause hospitalization also was much lesser in the TECOS, which we didn't observe any other DPP-4 CB outcome trial. So then finally I will come to about the heart failure. Is it a class effect? We saw it in the Sebertimi. Trend was seen in the examine, but if you meta-analyze, there is no signals. So can I use in a patients with heart failure? That I will tell you. So when you see the data of DPP-4 inhibitor, if you combined all DPP-4 CB outcome trial, this signals of heart failure is disappearing moment you add TECOS and Carmelina. Further down, if you see all the trials together which looked into heart failure, including BIBID with vildagliptin, Omnion with omarigliptin, again this heart failure signal seems to be disappearing, which was seen in the Sebertimi. So but this whether heart failure with Sebertimi is a chance finding or is really related to sexagliptin is not exactly known. In fact, we wrote this later and says FDA to withdraw this heart failure with DPP-4 inhibitor after this meta-analysis. If you closely look into ADA-ESD guideline, you would be surprised to see that on your right-hand side, what happens to what drug to give in patients with predominantly heart failure, and you would be surprised that this guideline also suggests that you use SGLT2 inhibitor or GLP-1 agonist. If your patient is not using GLP-1 agonist, then use a DPP-4 inhibitor with established heart failure data. So what is this established heart failure data? See this ESC-AHA guideline, very recently published. They are recommending that if you have got a patient with heart failure, first use SGLT2, then use metformin. GLP-1 agonist and sitagliptin and linagliptin comes into same class 2B recommendation with level A and B evidence. So ladies and gentlemen, what I thought to give you to make a difference between these DPP-4 inhibitor, all are same as far as CB neutrality is concerned. When I'm saying all are same, I'm talking about those who have undergone the CB outcome trial. So Sexa, Sita, Lina and allogliptin are cardiovascular safe. Heart failure was seen in Sebertimi but can't considered as a class effect. Only in reality Sexa had significant signals. There was some data of decrease in urine albumin excretion in the Carolina trial as one of the endpoint, but remember it was seen similarly in the Sebertimi as well as in the TECOS trial. So whether the reducing albuminuria would really benefit is not known. You need to have a hard renal endpoint. When you're talking about Sita and Lina seems to have equally similar in cardiovascular safe data on all hard endpoints, so they have a robust cardiovascular safety. Perhaps Sita has few additional points which I have shown you. in terms of advantage in female as well as in elderly. Vildatanali and evogliptin doesn't have any robust CV safety confirmation yet, and I do feel that they do need to undergo CV outcome trial, given that sexagliptin alone showed increase in heart failure. We don't know the status of heart failure with vildatanali and evogliptin. So when you are prescribing a DPP-4 inhibitor, choose wisely. Thank you very much for your patience listening.